Hi, and welcome to Healthy Living. We are here today with Dr. Richard Allen. Thank you so much for joining us. You're an interventional radiologist, and we're talking specifically today about lungs. What I'd like to do before we really get kind of narrow into that and dig deep is talk a little bit about your background, because I know that you're from Miami of Ohio, and that's very important to us.
That's right. That's where I did my undergrad, was at Miami of Ohio. Went on being a northerner. I trained at the University of Cincinnati. Went into radiology and did my residency at a place called Geisinger Medical Center in sort of mid-state Pennsylvania, and then went on and did a 2-year neurodiagnostic and neurointerventional fellowship at the University of Michigan.
How long have you been here at Hilton Head Hospital?
6 years.
Talk to us a little bit specifically then. We're talking about a lung screening that is sort of on the horizon, and we're really thrilled to be able to do that here. Talk to us a little bit about what that looks like and why it's so important, Richard.
Well, it's great. You know, with smoking being as prevalent as it is in the world.
Which is shocking.
Yeah, it really it raises the risk of many cancers, not the least of which is a lung cancer. And we've always been, how do we find these cancers earliest, and so we can get some treatment to these folks. And for a long time, we were just taking chest x-rays. And you get a yearly chest x-ray, it looks okay. But now we've found, certainly over the decade since we've had CT, that CT detects significantly more things than chest x-ray. So a large study came out, and they had 50,000 patients, and they followed them, chest x-ray versus screening CT, and found that there's an absolute 20% reduction in lung cancer related to death with CT screening versus chest x-ray. So it's a significant reduction in death if you can detect it.
Who basically would order this screening? Who would be a candidate for it?
So there is a finite group of people that are best served by screening, and certainly it's the folks that have the long-standing smoking history. There's one of to get enrolled in the study, it was a 30-pack year history, and pack year smoking history is if you smoke a pack a day for a year, that's 1 pack year.
Got it.
And if you're a two pack a day, then in 15 years you're at 30-pack years. So 30-pack year history was sort of a standard cutoff. If somebody's quit smoking, you want them to be within 15 years of that time. So once you've quit and you're beyond 15 years, you've actually lowered your risk to the point where you're not a high-risk patient anymore. So
to qualify for this screening, is there also a genetic component or an age component?
Age 55 to 74 was in the study, but 55 to 80 is sort of the range where we would recommend getting a screening. Genetics, not too much. I mean, there is certainly, if you have a strong family history of cancer, then any screening of any kind is going to be important, but that's sort of the lower down the
So once they have the CT and you register a finding, or it looks suspicious, what happens then? Take us through the process.
So when somebody sees their physician and they decide to get a screening CT, they'll come into the CT scanner. If anybody's had a CT before, you lay down at a table. The scan actually takes 6 to 8 seconds, so it's very fast. No injections of contrast or anything. You just lay there and you go through the machine and you're done.
This is good.
Yeah. So we'll look at the CT scan, and here's just a picture of what a single image of a CT looks like. It's essentially a person. Typically, you're sort of sliced like a loaf of bread, and we just get to look at little slices one after the other, and we can see if there's any abnormalities, particularly in this case in the lung. And so if we find an abnormality, depending on the size and what it looks like, we'll refer a patient to a pulmonary specialist. They will evaluate how to treat the patient, and sometimes that may be an additional diagnostic study, such as a PET scan. It may be a biopsy that we do with CT guidance. Sometimes a thoracic surgeon will do actually an excisional biopsy if they think they can treat and diagnose at the same time. But so there's a lot of different steps that may happen, but the first thing is to get with the pulmonary specialist after something's been diagnosed.
And then once the intervention is completed, I've always wondered this, is there a follow-up CT to sort of see where you are within the...
Yeah, so if they've had a definitive therapy, so we found a cancer and they've had their treatment, so then there will be, typically it's a 6-month follow-up, and then after that it spreads out to a year, but for a while you follow very closely to make sure everything's okay.
That makes so much sense. I really appreciate your time, Dr. Allen.
Absolutely.
Thank you so much.
My pleasure.
We will be back We are back. We are here with Micah, and you are the nurse navigator for the hospital.
Yes,
for
ma'am.
all of these procedures. Talk to me a little bit about what you do.
So as a nurse navigator, I coordinate care and act as a resource for patients and physicians.
Okay.
So pretty much we have our CT lung screening program, and basically for that to be covered, a patient has to have, they can have Medicare or private insurance.
Okay.
If they don't have either of those, they can do cash pay, which is $175. But for insurance to cover it, they have to be between 55 and 77 years old.
Got it.
They have to be a current or a former smoker in the last 15 years. They have to have a 30-pack smoking year history.
And what does that mean?
So they have to, if they didn't smoke a pack a day for 30 years, which would be a 30-year history, there's like a little calculation that we do.
Okay.
So if they smoke a half a pack every day, and then you have to multiply it by a certain amount, that can equal 30 years.
Okay.
And then they also have to be asymptomatic. They can't.
And what does that mean?
Like they can't be coughing up blood or anything that might be a sign of lung cancer.
Okay. How do people find out about this program?
So we've been doing some advertising, and a lot of the physicians in the area are also familiar with it, just because I've put myself out there to let them know what we have going on. Yeah.
So how does it really work with you? You take them from inception, they walk in the door and sort of walk them through this process?
So no, actually, the physician usually orders the CT lung screen.
Got it. That makes sense.
Or they can come to me. I have a specific phone number they can call. It's 843-686-LUNG if they're interested.
Oh, there you go. Perfect.
Yeah, it makes it easier to remember it. But what I do is I go through a database. I check it daily.
Okay.
And it has all the CT lung screens that come through that doctors in the area have ordered.
Okay.
If anything is abnormal on one of those CT screens, which Dr. Allen will usually make notes, the radiologist, I'll reach out to the local practice and say, hey, I just want to let you know your patient's lung screen has an abnormal finding.
Okay.
Would you like me to hook them up with pulmonology or cardiovascular thoracic? And what that does is it speeds up the process.
Oh, it expedites.
Yes, because a lot of the times it takes a couple weeks to get into these practices, and what I can do,
expedite that.
Yeah.
Do you actually talk to the physicians, not to the physicians, but to the patient?
I do, in certain circumstances, like if they call me directly and have questions about it and want to set it up specifically through me. Other than that, the only time that I would speak to the patient is if they came in our clinic for like a follow-up appointment to discuss one of these abnormal findings.
So what happens once you get them connected to either the pulmonologist or the next step?
So usually what I'll do is I'll send the information that from that visit back to their primary care provider, so they're always in the loop.
Okay.
And then the pulmonologist or the cardiovascular thoracic surgeon makes the next step, like do they need a biopsy? Do they need a PET scan? Do they need surgery to have it removed? Just depending on what type of cancer it is, or even if it is a cancer, it could just be a benign finding.
Once they've reached that point, do you take them kind of circular through the whole thing, or do you kind of hand them off to the doc at that point?
Actually, we like to follow them.
Okay, so that's a good thing to me, yes.
Yeah, so like say there's categories when you get these findings, and say there's a category 3 by chance, that's something that is suspicious,
okay,
but not necessarily anything needs to be done at this point, so we'll schedule a follow-up CT scan in 6 months or 12 months and go from there based on what it looks like.
Is this CT lung screening primarily for smokers, or is anyone else available to or meet criteria to have the screening?
So, for example, I had somebody call the other day.
Okay.
No history of smoking, but they worked in a coal mine for several years. And there is history of lung cancer with that. Now, he didn't meet the criteria for insurance, so in that circumstance, he paid the cash pay price, because sometimes it's just like having that peace of mind.
I just was going to say, that's peace of mind for sure.
Yeah.
Yes.
So that's where he falls in that place. So you don't have to be a smoker to do it.
Just look at the other criteria. It's really interesting, and once you have that database, that screening can really be helpful.
Yes, absolutely. I highly recommend it. And then I was also really excited when I was asked to be a part of this because I had a grandfather to pass away of lung cancer 4 years ago, and if something like this was around at the time, he possibly could have survived.
And this is a really new technique too, isn't it?
I believe
the screening.
Well, actually, the funny thing is, when we were out meeting local doctors, they said that the old cash pay price was $8,000. Yeah, so if you weren't covered, you couldn't get it covered by insurance. It was
it was cost
out of
prohibitive.
reach.
You couldn't do it. Oh, I really appreciate this. We're going to talk to Dr. Kellerman, find out a little bit more. So I really appreciate you joining us. Stay with us. There's more on healthy living.
Okay.